Welcome, everyone. We'll just wait a few seconds while everyone from across the country and internationally starts to join on the webinar. Everyone knows it's my favorite introductory icebreaker game is to use our chat box in your Zoom toolbar to let us know where you're tuning in from, what city or province, territory, country. Type that in the chat box here just so we can get an idea of where you're coming from. While you do that, I'll introduce myself briefly. My name is Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. And I'm very happy to be presenting today, or I guess moderating today, with Cathy Burrows, who you very much know from our first session on venous leg ulcers, which was part 1 that we had just about a month ago. So today's presentation is going to be called Venous Leg Ulcers Part 2, Addressing the Clinical Challenges Treating VLUs. And as I mentioned, it's going to be presented by Cathy Burrows, and I'll be introducing Cathy in just a second. Before I do that, just a friendly reminder that we will be having a Q&A portion at the end of this webinar. And to ask a question throughout the presentation, please just click on the Q&A box in your Zoom toolbar and ask a question there. That'll make sure that both Cathy and I can keep track of all the questions coming in and gives us a really effective and efficient way of answering them for you at the end. Without further ado, I'm going to introduce Cathy. So Cathy has a broad range of clinical backgrounds with over 20 years focused in wound care. In 1999, she developed and coordinated the leg ulcer clinic at the QE2 Health Sciences Center in Halifax. And Cathy has been an active member of Wounds Canada since 1999. She's chaired also numerous committees and was president from 2007 to 2009. In 2007, she was the recipient of the Excellence in Nursing Award, College of Registered Nurses of Nova Scotia. And in 2008, she completed the Masters of Science in Community Health, Wound Prevention and Care at the University of Toronto. Cathy has authored and co-authored numerous articles and book chapters on wound care. And she's also a clinical advisor to Wound Care Canada since 2011 and is presently co-lead with the Best Practice Recommendations Update and co-lead for the Wounds Canada Leadership Program. Cathy is a clinical and educational consultant for Perfuse MedTec Inc. So without further ado, I'm going to pass over the mic to Cathy. Thanks so much, Cathy.
Thank you, Troy, for that introduction. And thank you to everyone for joining us tonight. Hopefully, most of you have attended part 1. So on behalf of Perfuse MedTec Inc., thank you again for taking the time to join us. So the objectives for this evening, I'm going to review briefly the take-home messages from part 1 and identify the key factors that can impair wound healing and discuss the strategies to meet the challenges of treating and managing VLUs. And I'm going to very briefly discuss the concept of wound merge in advance. So as a review, we looked at most common of lower limb ulcers or venous leg ulcers are 70 to 80%. They have a long healing trajectory with approximately 30% unhealed at week 24. They have a high recurrence rate of 50 to 70%. And 25% have an arterial component. Most often they're located at the medial malleolus. However, as you can see in these photos, not all venous leg ulcers occur in the malleolar area. They can occur laterally and to the gaiter region. Venous hypertension is the result of reflux or obstruction and calf muscle pump dysfunction. And again, you would have seen this in part 1, where we look at the etiology, pathophysiology of venous leg ulcers. What happens is that there's valvular incompetence, or they get reflux from the vein where the valve is not working properly. And instead of the blood being pushed back up towards the heart, it actually goes backwards and into the tissue, or causing more swelling and edema. The biggest, one of the biggest factors and causes for venous obstruction or venous incompetence is a DVT. And most often it's more common in women, and most often it's peripartum, and it's never detected until much later in life when they develop a venous leg ulcer. And we know that calf muscle pump dysfunction is certainly a predictor of non-healing in these venous leg ulcers. And this is just speaking with the calf muscle pump dysfunction. You need to do a proper assessment to assess the function of the calf muscle pump, determining the range of motion at the ankle joint, strength of the calf muscles, and the gait pattern. And this is just a little video clip to show you how to do an assessment of the ankle and joint motion. And as you can see from the video, there's very little dorsiflexion there. Sorry. Yeah. So you want at least 10 degrees of dorsiflexion to fully activate the calf muscle pump. And calf muscle pump dysfunction is a strong predictor of VLU severity and healing. And the etiology, of course, is the venous pressures in the deep system, which are these, the deep system is here. And when the patient or the individual is supine, the pressures are 0 millimeters of mercury. And when standing, the pressure is about 90 millimeters of mercury in the deep system. And of course, you have the superficial. These are perforating veins that connect from the deep to the superficial. And in the superficial system, when they're supine, it's 0 millimeters. And when they're standing, it's 15 millimeters. And the reason that's important is because of the fact that when you are trying to determine compression therapy, how much pressure do you exactly need? So with differential diagnosis, in particular for nursing, we want to look at, again, the location. So with venous leg ulcers, as I said, it's usually in the malleolar area or the gaiter region, as opposed to arterial, it's in the distal digits. And in the diabetic foot, it's on the plantar area, usually over the metatarsal heads or over a pressure site. For venous leg ulcers, the wound shape is irregular, as opposed to arterial, it's very regular, punched out. And in diabetic ulcers, it can vary. The wound bed with venous leg ulcers are very sloughy and highly exudating, as opposed to with arterial, it's pale and dry and often necrotic. With venous ulcers, the edema in the lower leg and foot is quite significant. Usually with arterial, if there's any edema, it's localized in and around the wound itself. And with a diabetic foot ulcer, it's usually in the foot. Patients with venous ulcers often complain of heavy aching relieved, that are aching, and it's relieved with elevation, as opposed to with arterial. We know it as claudication or night pain. And if you elevate the limb, it will actually create more pain. And in the diabetic foot, it's insensate, or they have no sensation. The skin, of course, in the venous ulcers, they often have dermatitis, there's hemosiderin, and they will display atrophy blanche. In arterial wounds, there's a lot of erythema or redness around that wound site, which is a flushing of trying to compensate for the ischemia. The body's trying to get more blood into that wound. And with the diabetic foot, the skin is very, very dry. So here's the first polling question for you. Question number 1, compression therapies can be categorized by which of the two? So number 1, is it elastic with high resting pressure and low activity pressure? Is it elastic with low resting pressure and high activity pressure? Inelastic with low resting pressure, high activity pressure? And inelastic with high resting pressure and low activity pressure.
And so we'll just leave that open for a couple more seconds.
Sure.
It looks like we've got quite a few people still answering. Amazing. Maybe I'll show it now here. So hopefully you can see the results there.
Okay, yeah, right on. So in actual fact, this is, no, I'm not advancing here. Oh, here we go. So, sorry, with the compression categories, if you have an elastic system, which is like an ACE bandage or something of that type, you actually have, it's called long stretch, and you have high resting pressures and it's low with activity, as opposed to the short stretch or inelastic. And most often that's the 4-layer or 2-layer compression systems, or there's other proprietary compression therapies out there that have inelasticity, but their compression is low when it's resting, but high when it's activity. And that was one of the questions that came up in our last presentation, was should the patient who is ambulating, do they need to have compression on all the time? And if they're in a 4 or a multi-layer compression system, they're usually on for up to 7 days, depending on the amount of drainage. But if the patient is in a compression hosiery or some type of compression that they can remove, when they are lying down, just like I showed you in the etiology, there's 0 millimeters of mercury in the system. So they actually can take them off while they're sleeping. And then once they ambulate, they need to get them back on right away. And here's question number 2, which is the most appropriate compression for your patient?
And just a couple more seconds. And here we go. You should see the results now on your screen.
Yeah, interesting. That is very interesting. So in fact, let's go through this again. There we go. As we know, compression remains the gold standard, but this was a Cochrane review that was done in 2012. And it looked at compression increases ulcer healing rates compared with no compression. And multi-component systems are more effective than single component systems. And multi-component systems containing an elastic bandage appear to be more effective than those composed mainly of inelastic constituents. And the 2-component bandage systems appear to perform as well as the 4-layer. And patients receiving the 4-layer bandage systems heal faster than those allocated to the short stretch bandages. And more patients heal on high compression stockings than the short stretch bandage. But interestingly enough, that was 2012. This is another updated Cochrane review that was only done in 2021. And they looked at 14 studies with 1,391 participants in the review. But they felt that most of the studies were small and that 71.4% were at high risk of bias. So that just speaks to the fact that a lot of the papers that they probably reviewed were conducted by the companies that have these products. But if using compression bandages or stockings, people with venous leg ulcers probably experience complete wound healing more quickly, and more people have wounds completely healed when they are in compression. So the use of compression bandages or stockings probably reduces pain and may improve disease-specific quality of life. However, when we try to figure out what is the right compression, the right amount of compression therapy, it's the one that the patient is going to wear. And, you know, you've probably all experienced it, to put somebody in a high compression system, and they can't take it off after, they can't keep it on usually within a couple of hours. Or in my experience, I'd put it on them and they'd leave the clinic and you'd see them getting in their car and they're taking the bandage system off because they just find it too uncomfortable. And even though the risks are low, there was a study, it was not a study, but it was a international group of experts. There was 15 on the panel. It was led by Rabi et al. This was a 2020 paper. And they looked at the most frequently reported non-severe medical compression therapy associated adverse events included skin irritation, discomfort, and pain. And I just wanted to, show you that clearly this is causing a lot of irritation and discomfort. And for this particular patient, severe maceration, which speaks to the fact that you need to have some type of highly absorbent dressing to capture all of that fluid, because otherwise, when you have maceration, it's dead tissue and that has to be debrided. So question number 3, all of the following are factors that impair wound healing except.
So we'll just leave that open for a couple more seconds here. Got quite a few different options there to choose from. Looks like we got about 30 of you to answer. Awesome, and we're well over 50 now, so maybe I'll share the results. Is that okay?
Sure.
Perfect, and you should be able to see it now.
And that is absolutely correct. An ABI of 1.0 is normal. So the key factors that do impair wound healing are edema, ischemia, bacterial burden, medical conditions such as diabetes, congestive heart failure, renal disease, anemia, poor nutritional status, and medication. So with edema, as you saw with this picture with the maceration, and then this particular picture here, it often, I get comments that it looks like it's distorted. In actual fact, that is what is pretty close to what that limb looked like. But you can see all here of from the lymphedema where the skin changes have occurred, and there's a lot of it's like birch bark tissue. Edema is the accumulation of fluid in the interstitium or in between the tissues. It results in skin changes leading to heaviness, burning sensation, pain, dermatitis, and infection. And it predisposes patients to small breaks in the skin, which allows the microbes to enter. And lower leg edema can be unilateral, bilateral, acute, like a DVT or a traumatic injury, or it can be chronic. And one of the things here too is as nurses, of course, we don't prescribe unless you're a nurse practitioner. But when you see a patient with just on one side having edema, it's usually caused from some type of interruption in the venous system. It doesn't require to have a diuretic to get rid of that fluid in that limb. However, if it's bilateral, then it needs to be further investigated because that's usually related to some medical condition such as heart failure. Edema fluid neutralizes the fatty acids in the sebum, which reduces the inherent bactericidal properties of the skin. So that's why they are so prone to infections. And of course, chronic edema leads to lymphedema. And this you would have seen in part 1, but clearly here there is definitely edema that you can press and see the indentation in the skin. as opposed to here, there's blistering. And that's usually caused from so much tension on the tissue and is secondary to maybe heart failure or some type of organ failure, or low serum albumins with malnutrition. And ischemia is a restriction in blood supply to any tissue, muscle group, or organ, causing a shortage of oxygen needed for cellular metabolism. And the causes can be atherosclerosis, it can be an embolus or thrombus, and it can be trauma. And it presents as intermittent claudication, or when the patient is walking, they complain of pain, most often in the calf. And you can determine just by your history, when you ask them how far they can walk, and they tell you, oh, I can walk a couple of blocks, but then I have to stop. It's not severe. However, if they say, I can't walk across my kitchen without pain, or I have to keep my leg out of the bed overnight, then that's severe ischemia. And for those of you who are either working in a hospital setting or in a long-term care setting, when you do your rounds, if you see these patients with their legs hanging over the side of the bed, that should be a little reminder that they probably have peripheral arterial disease that is significant. And when they have this ischemia, the wounds and the tissue become necrotic. And this particular picture shows where a patient did have compression on. And I always want to make note here that this should have been a red flag for someone who applied that compression therapy, because as I showed you in the differential diagnosis, arterial ulcers are usually located distally, and they're usually necrotic. So this should have been a clue that this patient had arterial disease. And of course, bacterial burden or infection. And this is just a whole field in and of itself. But wound infection develops as a result of the microorganisms invading the tissues and these biofilms. It can be local or systemic in response, and it's significant exudate and edema, stasis changes of the skin, and arterial insufficiency can all contribute to bacterial burden or infection. And I think what we see here, when you get these biofilms, they definitely have to be debrided, because when they form in the wound, they're surrounded by a gelatinous coating, so it protects them from you can't get antibiotics to the biofilm. The breathing and the respiration, it just goes down to almost nothing. So there's very little oxygenation going into the tissue and excreting the waste. So they really have to be debrided, whether it's mechanical or whether it's surgical debridement, whatever is your method of debridement. And I always say to clinicians that when you have, say with a new treatment, especially an antimicrobial, often in the first couple of weeks or the first few days, you see, wow, this is amazing. It's cleaning the wound up really quickly. But what happens, I think, a lot of times, if the patient is not properly debrided, is that these antibacterial dressings, they will just clean up the free-floating bacteria. They don't get to the bioburden. So that's why if you debride and then put these dressings on, it will get to the bacteria. And this is question number 4. Which of these pictures demonstrate infection?
All right, we're getting tons of responses right away. We'll leave it open for a couple more seconds. And already just over 50 people now. Last chance, and we'll end it now. And you should be able to see the results on your screen now.
Okay, perfect. So with this particular one, you can actually see the outline of the dressing. So that tells me that that is a contact dermatitis caused from the dressing. This particular wound is systemic, and there's cellulitis that's going right up the leg. So that is that's more advanced infection. And this particular wound here, whenever you see erythema or redness greater than 2 centimeters around the wound, then that's usually one of the indications that that wound is infected. So it's more localized as opposed to the cellulitis going right up the leg. It's that's more systemic. So oftentimes with this particular type of wound, if it's localized, we can manage that with some antimicrobial dressing, as opposed to this particular scenario where the patient will require parenteral antibiotics, whether it's IV or PO medication. And we talked about the medical conditions that are related to impacting wound healing. And of course, heart failure is one of them. Liver disease, such as cirrhosis, renal disease. If they have renal failure, then it's going to impact wound healing. If they have had a traumatic injury, and if they are malnourished, then it's going to really impair that wound healing process. So it makes them more of a challenge to, they become chronic and often are a lot more difficult to deal with. And medication, of course, the non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen, naproxen, Clovanac, which is Voltaren. The glucocorticoids is like prednisone and any of the derivatives of prednisone and the anti-inflammatory effects of that. Aromatase inhibitors such as breast cancer treatment drugs can impact wound healing. And the vasodilators, whether it's arterial or venous, calcium channel blockers, the hypertension and cardiac arrhythmias are treated with the calcium channel blockers. So all of that can have quite an effect. So with geko wound therapy device, how can it help wound healing outcomes? Well, again, I just wanted to bring up this. We saw this the last session. This is what the device looks like. And it is smaller than the watch that I wear. And it's very, very easy to use. It's got a plus sign and a negative sign. The plus sign turns it on. The negative sign turns it off. And when you initiate this, when you press the positive, you'll start to see the green light flashing. And there's 10 settings. So from 1 to 10, 10 being the highest level of stimulation that you're going to get. And this is an example of a patient with an arterial wound where you can see there's a lot of chronicity in that wound. The edges are quite rolled. This is before geko was started. And then this is after geko has been on. And you can see quite a significant uptake in the microcirculation in and around that wound. In particular, that wound edge, I find that extremely interesting. The fact that there's so much uptake in that rolled edge. And this is a study, a randomized controlled trial that was done in London, Ontario at London Health Sciences Centre. And it looked at post-op kidney transplant patients, and they had 221 patients enrolled in this clinical trial, and they used geko for the active treatment, as opposed to standard of care was intermittent pneumatic compression and TED stockings. And as you can see here with the parameters, even though it was post-op kidney transplantation, these can be transferred into other areas that we see in wound care. In particular, leg edema was significantly reduced in the geko group. Weight gain was significantly lower. The urinary output was quite a bit higher in the geko group, and the femoral velocity was quite significant, improved with the geko. And these patients were able to be discharged a day earlier, the ones that were in the geko arm of the trial. And when they went back and looked at all the other areas, they found that there was a cost savings of about $2,300 per patient who were on the geko device. And as you know, the P levels for all of these parameters reached statistical significance. And then I'm going to talk to you a little bit about wound margin advance. You'll be hearing about this further down the road. But what it is just another way of measuring the wounds and comparing them to see if they are improving. And the equation here is that it is the area over the perimeter of the wound, and the measurements are conducted weekly for whether it's 4, 5, 6 weeks. And as you can see in this, you look at wound A and wound B, and they're measuring from the edge in. Oh, sorry. And this just demonstrates, here is wound A, which is a bigger wound, and as opposed to wound B, which is a very smaller wound. And if you are measuring the normal, or what we normally would do is wound surface area, then you may think that wound A is healing a lot better than wound B. However, with wound margin advance, you can see that there is wound A and wound B are healing at the same rate. So that measures the linear advance of the wound edge inward. So again, this just shows where if you've got a big wound and a smaller wound, doing wound margin advance, it demonstrates that they are healing at equal rates. And with this type of measurement too, there's no bias as far as saying that one wound is healing quicker than the other based on the size. And this was a evaluation that was done by Holly Murray, and she looked at 18 patients with venous leg ulcers and had the geko devices added to the treatment plan as soon as possible. And this was an independent evaluation. She was not supported through Perfuse with this. She just decided that she wanted, she had seen patients being put on geko later on, usually 90 days, and then they'd start geko. But she started them on the first visit. And what she saw was that there was a significant improvement. These are the numbers here, where the healing, the closing time had improved significantly. It was over 50% quicker using early intervention with geko. And this is the effect here, the rate of wound margin advance. And you can see this is standard of care versus standard of care plus geko. And it's definitely more than 50% improvement. So really the take-home messages here is identify the key factors that can impair wound healing, as we discussed, and then look at the strategies to meet the challenges of treating and managing these venous leg ulcers. And then again, I just gave you a brief sort of overview of wound margin advance, because Dr. Keith Harding, so Professor Keith Harding, will be discussing his randomized clinical trial that he conducted in the UK. And he will be talking about wound margin advance in his presentation and the impact that geko had on treating these venous leg ulcers. So it's just a little intro before Dr. Harding presents at the NSWOCC meeting, hoping that you will be able to join us for that. It's May 5th from 5:30 to 6:30 Eastern Standard Time. And we're pretty excited because this is going to be the first time that he's presented his work with this clinical trial in North America. So NSWOCC will be the inaugural presentation for Dr. Harding and his study. And these are some references. I'd be happy to provide them for you if you so wish. And I think that's pretty much it. We're going to be open for some questions.
Thank you so much. And definitely, we are so excited to have you at our NSWOCC National Conference. We're less than a month away, just a few more weeks now. So definitely make sure if you haven't got your ticket already, this is my shameless plug to go check out our website at nswoccconference.com to definitely get a little bit more information, especially about geko and Sir Professor Keith Harding there. They'll be fantastic. So first of all, thank you, Cathy. What a fantastic presentation. And thank you again to Perfuse MedTec. We do have some questions if you're okay to answer here. The first one being, can geko be applied for diabetic foot ulcers?
Oh, absolutely. Diabetic foot, we've got some studies and some posters and some papers on the impact of geko with diabetic foot ulcers. And we see a significant improvement because of the fact that you're getting increased microcirculation, not just to the wound, but to the peri-wound area and to the limb. So these patients with diabetic foot, as long as they're offloaded, you know, that's the big thing. It doesn't matter if you don't have them properly offloaded, then you're not going to, nothing's going to heal them. But with geko, you'll see a significant improvement with outcomes.
Fantastic. And I'm just going to invite to the screen as well, Derace, who's behind the scenes as well. Derace, was there anything else you wanted to add to that?
No, that's just fine. Thank you.
Derace is a colleague of mine, and she is the mastermind behind my slides. She does all the technical stuff with the slides. So thank you, Derace, for that.
You're welcome, Cathy.
So yeah,
so we do have a couple other questions here, so we'll keep it going here. So another one was just saying thank you again for the wonderful presentation. Can geko be effective in the initial stage of gas gangrene's patients? Does that make sense to you there, Cathy?
Yeah, it does. I don't think we've really seen a whole lot of that with gas. I mean, gas gangrene is a very it's not a good situation for these patients, and often it's just they're often amputated with gas gangrene. In my experience, anyway, Derace.
Exactly. That's exactly what I was going to say.
It's a medical emergency when you've got gas gangrene. It has to be dealt with, and it's usually amputation. So at that point, it's too late for geko. That's why early intervention is so critical. Yeah.
Perfect. Okay. Well, thank you for touching on that. Another question was just about any contraindications to geko, such as DVT or permanent implanted pacemaker or defibrillator.
There's no contraindications for geko. However, there are some precautions, and you really, if a patient has an active acute DVT, do not use geko, because what happens is that when you get the contraction of the calf muscle pump, you do not want that DVT to become an embolus or thrombus that's traveling. So unless the patient is under, controlled medically with medication, and they're a couple of months out from their active DVT, I wouldn't recommend geko.
However, the geko is recommended for DVT prevention.
Yes.
We have a couple of, I'm not sure if they're studies, Cathy, or if they're case studies where they've been used during pregnancy for DVT prevention and post-operatively in ICU when the patients can't receive anticoagulants, and also post-orthopedic surgery.
Yeah.
Perfect. All righty. And we have a couple more questions coming up here. I'm just checking the time to make sure we're good. We still are. Fantastic. So Terry was just asking if you maybe could go into just a bit more detail potentially on the pathophysiology behind geko, or how it might work on more of the microscopic levels. Is this something that you'd be able to touch on, either of you?
Yeah, well, what happens is the device has to be placed over the common perineal nerve. And when you get it placed over the common perineal nerve and activate the device, then it stimulates the common perineal nerve. And that actually causes an antagonistic effect with the other muscles, the gastrocnemius, and so you get that, when you get that contraction, that's where you're getting the effect of like physiologically you're getting the effect. So it's the same as if you were walking for about 3 hours. You're getting the same effect, the exercise of that calf muscle to get the blood out of the limb and get the edema out of the limb. And we know with geko that it's not just driving the fluid, repositioning it, it's actually systemically getting rid of the fluid, because all of the different patients evaluations that we've done clearly have a significant increase in urinary output, which speaks to the fact that it's being taken out of the tissues and excreted through the kidneys. And just as I think of it, there was a question about a pacemaker, and I don't think I addressed that. If the patient, they can still use geko if they have a pacemaker, but the physician, their physician or practitioner needs to be aware, because if they go to have an EKG done, it really should be turned off so that there's no artifact in the EKG. So I think that would answer that. But otherwise, there's really no other precautions. Darius, would you say? Yeah.
Good. Well, thank you for covering both of those there. And now I've got sort of two people who are asking a similar question here. They were asking about if you had a bilateral edema, would you use 2 gekos or is 1 sufficient? That's kind of the main question from both of these people.
You could. That's a real. If they have a wound on each leg, then they definitely need to have a geko on each limb. If they've got bilateral edema,
I think Cathy, with bilateral edema, yes, I think you addressed in your talk that there's another reason why they have the edema, and if the geko device is on both legs, they do get systemic blood flow.
Yeah.
Increase in the systemic blood flow. So we did an evaluation at London Health Sciences Centre in the coronary, sorry, I'm losing the word here.
In the ICU?
In the, anyway, where they put the wires into the
in the cath lab.
coronaries. In the
Yeah.
cath lab, thank you, in the cath lab. So they and they had increased blood flow in the coronary arteries with the geko device on both legs. In the coronary arteries that weren't blocked, they had increased blood flow. So it does show that, you know, if the patient's kidneys are working and you get the geko devices on, then they're going to have increased urine output to help get rid of that edema.
Perfect. Well, thank you for touching on that. Another question coming in here, and I'm seeing it in the chat in the question as well, is would this be a therapy that would often be used in home setting as well?
Oh, 100%. I mean, that's where it really shines because of the fact that, you know, during the pandemic, we were pushing for people to use it because in the community, because most often patients or their caregivers can apply it as long as it's the patient is, they identify, a nurse or clinician identifies where the common perineal nerve is over the fibular head, marks it, the patient or their caregivers can apply it themselves, which makes it such a more, you know, it's so user friendly. It's very easy, yeah, to use. So in the home setting, absolutely, that's the ideal spot. Yeah.
And we found that by having the patients participate in their wound care, by adding the geko device, that they get quite engaged in the whole process, and sometimes are, you know, more compliant with their adhering to their compression therapy, etc.
Yeah, they feel like
Fantastic,
that they are part of the team, which they are. Yeah.
Fantastic. Moving on to a couple more questions here. One is just asking about whether this would need a physician's prescription before using.
It depends, I think, on where you're located. In Ontario, the NSWOCCs, I believe, are able to recommend it or order it. Other provinces, they require a physician. Here in Nova Scotia, we have wound consultants that work through the Department of Health Association of Nova Scotia. It's a fairly new program, and there's 6 consultants now, and so they're able to order it. But I think in the other provinces or territories, they likely would have to have a physician order.
However, you can call the phone number, and we can provide that to people. You can order it for yourself or for your family member. That it does not require a prescription. It's just that certain districts have put guidelines in place that require a prescription from a physician, or at least maybe not a prescription, but at least an okay from a physician. But it's perfectly safe. People use them on flights. Sports teams are using them now for sports recovery and sports injury, for instance.
And I guess sort of on that note as well, and it varying across Canada, would you be able to just let us know what the best way is for if someone wants to get more information about either cost or whether it's covered by insurance, or if there's any funding opportunities? What would be the best way to find out more information for their province or territory?
Well, if they can reach out to me, and we have a product specialist in Ontario, Paul Reed, and he's quite familiar with all the process in Ontario. But just send your inquiry either to me directly, or you can send it to the Perfuse info
at perfusmedtech.com.
Yeah, that's it. Yeah, thanks.
And what you can even do here is, if anyone wants to get in touch, if you want to just reply to the email you signed up with, or where you're going to get your certificate of attendance, we can always forward you on to either of our Perfuse MedTech contacts. So reply to any of us, and we'll definitely get you in the right direction.
Yeah, I mean, they can reach me. They can reach me directly, Troy.
Mm-hmm.
And just
Do you want me to maybe just type your maybe you want to put your email in the chat? Might be the best way here. Just in case they don't have it handy. Same with the Perfuse MedTech email if possible. In the meantime, and maybe a Durace while Cathy's typing that in, do you know
I'll
how
do that.
long the geko device lasts before it needs to be replaced?
So we have the geko device that's used for wound therapy is good for 2 days. So you put the geko device on for 12 hours. The first day, it will automatically shut off after 12 hours. You take it off and put it onto the backing that the geko device comes with. The next day, you put the geko device back on for 12 hours. After that 12 hours, it will shut off, and then it is all recyclable. So each device is a 2-day device. So it comes in a package that is 2 weeks of therapy. So 7 devices will last you 2 weeks.
Fantastic. And I'm just going to iterate Oswaldo's comment in the chat here saying that they were not aware of this device, but it offers a great solution to an important problem, the stimulation of the muscle pump of the leg. So thanks for your comment there, Oswaldo. Another question here from Terry comes in is, can this be used for an active infection, I guess an infection prevention or an infection prevention tool? Terry, hopefully I understand your question correctly. Does that make sense to you, Cathy, or Durace?
So they're asking if the geko
Can be used as an active infection. I'm assuming this is for a tool. Terry, if you want to just maybe reiterate the question a different way, maybe we can get to you. I'll remind everybody who are still online with us too. If you have any questions, please feel free to put that in the Q&A box or in the chat. We'll definitely be able to get to it. We do have a little bit more time here, so please feel free to ask them. We're happy to get to them. And
one of the things that I want to point out with that is that in Dr. Senner's study with the post-transplant patients, that was one of the things that the parameters that they found was that the wound infection rates were 50% less than with geko than they were with standard of care. And I think the whole idea behind if you're trying to, reduce infection or prevent infection is with increased blood supply and oxygenation, that helps with preventing some of the bioburden. But the big thing here is with debridement, and that's key. Is all that's pretty much all I can sort of say. Is it's key to keeping the bacteria down.
Perfect. And I see that Terry here has just clarified really quickly. So can geko be used with an active infection if a client is able to tolerate geko?
Absolutely, as long as they're on antibiotics. They have to be medically managed, with it. But even with the diabetic foot, that's the biggest problem with a lot of the infections with diabetic feet, is that the microcirculation is so compromised that a lot of times the antibiotic can't even get to that infection site. Whereas with geko, increasing that microcirculation up to 1,000%, it is going to get that antibiotic to the appropriate site, to the infection site.
Fantastic. Well, thank you for answering that, and thanks for clarifying there, Terry. I don't see any new questions in the chat here, but Lisa just put another one here. They hadn't heard about the device before. Has it been used out in the community for treatment yet? I think we talked about home care before. If you want to just maybe reiterate that.
Yeah, it actually, again, that's where it really is effective, is in the community setting where patients that are in their own home can manage it themselves, or their caregiver can manage it. So yeah, it's really appropriate for the community setting.
Fantastic. Well, I'll leave the chat open for just a couple more minutes here if there's a question that does come up. In the meantime, I will just remind everybody about where you can find a bit more information coming up soon. Again, just echoing what Cathy had mentioned there about Dr. Keith, Professor Keith Harding's presentation at the NSWOCC conference. So again, our conference will be coming up in just over 20 days. It's going to be live in Ottawa in person. but you'll be able to attend many sessions, but of course, a little bit more information here featuring Sir Professor Keith Harding. So just a quick reminder, you can find out more information about that at NSWOCCconference.com. That's NSWOCC with 2 C's conference.com. I'll put it in the chat here. But I would be yelled at by the board if I did not promote our conference. And we're really excited to hopefully see everybody in there. So I got, while I was doing that, we did get a couple more questions coming in here. So we'll stop sharing. We'll get back to our regular scheduled program. This was just asked by someone else here. Can it be used for amputees to promote healing for someone who has vascular problems? Has this been a case you've seen before?
Absolutely. And if they want it, again, reach out to me. I presented a poster at Wounds Canada this year. And it was on a patient who was diabetic. They had an amputation, below knee amputation on one leg, and they had femoral bypass on the other, with diabetic foot ulcers on their left foot. And that all healed perfectly well with geko. And I'd be happy to share those posters. I mean, if they reach out to me, I can send them, quite a bit of information. Yeah.
Absolutely. Well, yes, definitely. For anyone who's on the call here, we will be reaching out to you just after this webinar with the certificate of attendance as well. So what I'll do with that certificate of attendance, so maybe just add your email into that email there too, if that's okay, Derace or Cathy, just so it makes it easy enough to get in contact. So what I'll do here, I don't see any new questions coming in. So I just want to thank both of you again for coming on, and Cathy for such a fantastic presentation. We truly appreciate our partnership with Perfuse. We can't wait to see you at the conference coming up soon. So reminder to everybody, this has been recorded. You will be able to share this with your colleagues or rewatch it again later if you had to leave early or come in late. It's going to be available at nswocc.ca/webinar-series. All that information will be found in your certificate of attendance email, which you'll receive within the next 48 hours, so before the end of the week. Other than that, we hope to see you on our next webinars, and we hope to again partner with Perfuse in their MedTech in the future for another webinar. So thank you so much for everybody, and we look forward to seeing you soon.
And thanks, Troy. Thanks, Derace.
Thank you both.
Thanks, Troy, for all you've done. And thank you to everyone who has taken the time to join us this evening.
Absolutely. Have a great evening, everybody. Bye now.
Okay, thank you.